Okay, thank you so much. So I'll re-welcome everyone now that the tape is rolling. My name is Claire Courtwright. I am the Advocacy Director for Cal Voices, and this is Access California's second quarterly training webinar of the year. Access California is a program funded by the Commission for Behavioral Health of the state of California, formerly called the MHSOAC. So any opinions about policy are the opinions of Cal Voices and not the opinions of the Commission for Behavioral Health. A couple of housekeeping items. As I already mentioned, the webinar is being recorded. We don't allow for AI note takers for a bunch of reasons in these meetings, but once the recording has loaded, we will put it on our YouTube channel where captions can be turned on. Additionally, we do give out the slide deck. And so hopefully between all of those different formats of recording this training, it should be accessible to people who may have different accessibility needs. The training today will be somewhat lengthy. The agenda is also a set of learning objectives because it is a training webinar. So what I plan to cover today is to help folks understand how the community planning process under the Behavioral Health Services Act is going to look very, very different than the community planning process looked like under the MHSA. And since we are heading into our first community planning process that will create a plan under the new rules, under Prop 1, under the Behavioral Health Services Act, and not under the prior rules of MHSA. Now is the time to at least set some kind of expectations for how this will look different. And I'll go into what we do and do not know about how it might look given some of the rules from the state. But in order to understand how this community planning process is kind of going to look very, very different, it's first really necessary to understand what it looked like under the MHSA, what goes into it, and how that has changed. So hopefully if I do my job coming out of this, you will understand how the MHSA community planning process really has been fundamentally altered. And so that should set some expectations in the community. You should understand what the kind of the three pillars of the MHSA and BHSA are that affect that community planning process and the input that the consumer stakeholder population is able to give into the public behavioral health services that they receive. You should understand what a statute is and what a regulation is and why that matters, both now and in the future to these questions of client and consumer stakeholder input. And you should also understand the basic requirements of the community process as they were under the MHSA and as we look at them going into the BHSA. I will also say the point of this training is not really to get super into detail as to what this may end up looking like in different counties, but it is just to say, look, here's where it's going to look different and also why. In terms of deadlines and what's going to happen next, as of the end of April, the state of California Department of Health Care Services released what's called its DHCS County Policy Manual for BHSA. And that set of rules and requirements actually is law, has the force of law. So up until about 6 weeks ago, what the Behavioral Health Services Act really was literally still being written. So another caveat there that it's still very early days. And now that the final rules are out there, the BHSA is now written, it is now complete as a law. Now the process can start in the counties, and the counties have to have all the planning done by really the end of May of next year, because the plans need to be approved. And then the actual funding shift and programmatic changes really have to start by July 1 of 2026. So there is both some and not a lot of time. So for part one of this training, I'd really like to just kind of frame the issues. I'm using this phrase, kind of invented it to explain it to myself. What are these three big pillars that are affecting the community planning process? So really the three pillars are just the three components of the Mental Health Services Act, many of which were retained by the Behavioral Health Services Act. So the Mental Health Services Act envisioned local communities at the county level driving a process that would transform the public behavioral health system in each county. The Mental Health Services Act created a 1% tax on personal incomes over $1 million and dedicated that money to each of California's 58 counties so that local communities could design their own services and programs with some rules and restrictions. The Mental Health Services Act gave counties funding, so that's pillar one, rules on how those funds could be spent, that's pillar two, and created a public process through which the spending would be planned for by the community according to one and two, so that's pillar three. So we have money coming in through state tax collections, pillar one. We have rules about how that money can be spent, which is pillar two. And then we have the community planning process to plan for and spend those dollars. That's pillar three. So I'm just going to repeat that as a framework throughout to kind of stay grounded somewhere. So all three pillars or parts of the Mental Health Services Act are interrelated and affect each other. So if one changes, the rest are necessarily affected. So again, I'm going to call pillar one just the funding, the tax revenue and the laws that say how much of that tax revenue is given to the counties versus the state. That's one part of it. Part two is those spending rules. So, what does the law say, both in a statute and regulation, about how these MHSA dollars can be spent, now BHSA dollars. And then pillar three is the process, right? It's the planning and spending process, the public process that the law requires for counties to engage in to spend and to plan for and spend the tax revenues. So all three pillars of the MHSA were fundamentally altered by Proposition 1 in what's called the Behavioral Health Services Act. And these changes are very complex. And because all the pillars are interrelated and affect each other, they're even more complex. And so to understand the changes and anticipate how this first community planning process under the Behavioral Health Services Act will look different than it did under the MHSA, it's necessary to kind of like go through a little bit of a review and then compare and contrast. So any questions before we get started? I'm so bad at navigating this new Zoom interface. I need Jocelyn to tell me if there are hands.
No hands yet and nothing in the chat yet.
Okay, thanks. Okay, so then we'll just keep going. So let's review the Mental Health Services Act and the community planning process. So in this section, I just want to go over those MHSA dollars, pillar one, and some key takeaways about them. And then pillar two, the MHSA spending rules and the sources of those rules and some key takeaways there. And then pillar three, the MHSA community planning process and key takeaways. And probably everybody on this call is pretty familiar with the MHSA and the community planning process and have engaged in it. So this really will be a review, but hopefully just to highlight some pieces, and those are the pieces that are changing in the BHSA. So basic review, under the MHSA, the state collects these personal income tax revenues from very wealthy people, and 95% of those tax collections have to go to the counties. They get distributed to the counties by a certain formula based on population, some other things. But the basic rule was 95% of these dollars went to the counties. And then the counties had to spend them in a certain proportion. So their 95% of that, 76% had to be spent in one bucket, community services and supports, 5% in another, innovative programs, and 19% in prevention and early intervention programs. And then there were some subcomponents of those big buckets that people are probably familiar with. I'm not really going to go into what all of them were, just to know that at a very basic level, 95% of the tax revenues was going down to the counties. And then there were some very broad divisions of that money into percentages to be spent in different ways. So again, 95%, 5% to the state, and very few rules in the broadest sense. Within those broad categories that we just mentioned, there are other subcategories requiring counties to spend a certain number of dollars. So for instance, so I go back one just for the visual, community services and supports is all of that red of different shades, and full service partnerships was required to be at least half of it. So those are some of the basics that people are familiar with. And obviously, a key takeaway is that if the state changes the amount of monies that goes down to the counties from these tax collections, that affects the community planning process, because there's less money going to the community to spend and plan for in the community planning process. So that's one way that all these pillars are interrelated and relate to the community planning process. If the state keeps more money out of these tax revenues, that affects the planning process because they have less money to plan for and with. Any questions about that? Again, I'm going to need an assist from Joss until I figure out how to actually work Zoom.
No hands are raised yet. Just a comment in the chat from Stuart. A recommendation for following a certain podcast regarding MHSA money.
Awesome. Will do. I'll check that out. Okay, so pillar 2 of the MHSA, we got the tax revenues, we got the money. Pillar 2 was the more detailed rules for spending those dollars. The rules counties and the community must abide by in deciding what specific programs or services to spend really came from two sources. Right, so there's two sources of rules you have to follow. One is called the statute and the other is called the regulations. They're both laws and they both bind the counties and the community. You have to follow them, not suggestions, not policies. So a statute is really just the language of a law that's drafted and passed either by elected officials in the legislature, or in the case of Prop 63, the Mental Health Services Act, it was actually written by the community and passed directly on the ballot. Regulations are also laws, just like statutes. The reason why they have a different name is because somebody else gets to write them besides the legislature or the people. Regulations are laws which are drafted and enacted by agencies of the state of California when the statute itself says that they can do it, right? So in this case, the state of California, both in the Mental Health Services Act and in the Behavioral Health Services Act, said, hey, the California Department of Health Care Services is allowed to write the regulations, the more detailed laws that will dictate how MHSA dollars are spent. And those are called regulations, and DHCS gets to do it because it's an executive branch agency, and the leadership is appointed by the governor. So basically what you have is that the MHSA is really one law. It was written in two parts by two different groups of people. And so just to review, the part of the law that was written by, Mental Health America of California, Rusty Seelix, and the community and put directly on the ballot, said that it established the tax, it created the tax to tax millionaires, and then it said that the monies from that tax shall only be used to pay for the programs that are authorized in the law, and not for anything else. And you can't take them for any other purpose. So this part of the MHSA statute meant that if a county or a community, through the community planning process, wanted to fund a specific program or service with the MHSA dollars, it could only do so if it had permission to do so in the law, right? So we can't just spend these dollars on anything. It has to be spelled out in the law what they can be spent on. So Part of the MHSA was written this way by a statute. And that statute said that counties and communities could fund programs that fell into these very broad categories if it counted as the adult or older adult mental health system of care, an innovative program, a prevention or early intervention program, and then later No Place Like Home, and also the Children's Mental Health Services Act. So that was the very broad thing that was put in the law by the people, essentially. Um, but the people also gave the permission to DHCS, Department of Healthcare Services, to write additional and more detailed parts of the law called regulations that would just have the exact same force as law. So they did that previously through a very formal process called the Administrative Procedures Act. And so why does this happen? Why are two different groups of people writing one law and different parts of one law? It's really to put kind of flesh on the bones. Oftentimes, legislators write laws that are very broad and they're hard to make work in real life without someone making more decisions and more rules. So that's what DHCS did in the MHSA. It created a bunch more rules for what these things would mean, what would be fundable in the adult and older adult mental health system of care, innovative programs, PEI, but also DHCS put some more flesh on the bones of the law regarding the community planning process for 3-year plans and annual updates, and also the general standards for the Mental Health Service Act plans and more. So here's just an example of how this played out. So the people put it in the law that MHSA funds could only fund things like the adult and older adult mental health system of care, and then regulations to the MHSA that were written by the Department of Healthcare Services in consultation with the community gave further explanation as to what this was going to mean. So under the adult and older adult mental health system of care, regulations created a category called community services and supports, all that red stuff we saw in the pie. And then even more than that, it said there's going to be community services and supports as a subcomponent of the MHSA. And then that subcomponent is going to have full service partnerships, general systems development, outreach and engagement, project-based housing, and prudent reserves, and a bunch of other little miscellaneous things. And then to get even more down in the weeds with it, so this regulation said you could have a thing called general service development and you could fund things that counted in that category. And then they even said more what that would mean. So that's where you see things that we're really familiar with in the MHSA spelled out, right? Peer support, wellness centers, wellness and recovery centers, crisis residential, peer respite, drop-in centers, specialized homelessness shelters for people with serious mental illness. All of those things, the regulations gave affirmative authorization, explicit permission for counties to spend money on. And you can keep going. If you look at the law and say who wrote this part, a lot of what innovative programs means was written by regulations through the Department of Healthcare Services. And so then you get all this specificity that really is what we're used to in the MHSA. Well, what is an innovative program? It introduces a mental health practice or approach that is new to the overall system, or makes a change to an existing practice in the field, or applies to the mental health systems a promising community-driven practice or approach that's been successful in another context. So all of that detail, again, came from the regulations. And you can keep going. This is just for, I'm not going to read all of these. This is just to give you an example and help you, if you're familiar with the MHSA, locate in your own mind, where did this come from? Where did this part come from that I'm familiar with? And kind of the takeaway that I'll get to in just a minute here, because we see it with housing too. Housing was authorized in the MHSA, both in the statute and in the regulations. But what housing could mean and what it did not mean was really in the regulations. So we saw was permanent supportive housing. That means something, right? That's where the housing is permanent and you don't have to engage in the services to remain in that housing, but they have to be offered. like rental vouchers. Okay, housing means your own apartment. Short-term respite care. Okay, housing can mean short-term respite care. What can housing not mean? Long-term institutional care, long-term institutionalization, long-term involuntary hospital stays, or anything related to the criminal justice system. Um, and the regulations to MHSA also did a lot to prohibit all of these funds from being used in certain ways. So the MHSA said all the programs and services funded through the MHSA had to be designed for the voluntary participation of the client. The counties were not obligated to use these funds to fund court mandates, so like AOT or care court. Again, long-term institutional care was prohibited, no law enforcement purposes. A lot of this was the regulations. So again, why would I harp on this so much? It's just actually really important for the way that BHSA has developed, because the regulations to BHSA are just as important as the regulations to MHSA. And like I said, they were still being written. The law was still being written up till about 6 weeks ago. So statutes and regulations are both types of laws. They just have different names because of who's writing them. Either the legislature wrote the law or the Department of Healthcare Services did. But both the statutes and regulations have to be followed by the counties. The vast majority of what we all think of and what is the MHSA was actually created by and lives in the regulations. And those regulations gave detailed fund spending rules and prohibited MHSA funds from being used for certain purposes. So why does any of this matter? Because of those three pillars, right? I still want to refocus in the community planning process. So if any of the pillars change, the amount of money that's coming in, the rules about what you can and cannot spend that money on, if those things change, that affects the community planning process, because money and rules are what we're doing in the community planning process, is what we're applying. So all of these pillars are going to affect. So if either the statute or regulations to MHSA change, that affects the community planning process directly, because the counties and communities have to follow all of those laws. I'm going to pause there for any questions, and Joss will Vanna White the hands for me, but I don't know why I have such trouble opening the chat.
Yeah, nothing in the chat so far, and no hands just yet. Oh wait, we do have a hand from Michael.
Go ahead, Michael.
Yeah, I've been going to the transition task force meetings in San Mateo. And I had asked a few questions about peer support, and I know we were just talking about that and there needing to be like specific things. And I felt like I kind of like got a little bit of a runaround on it. She kind of passed off the question. There was the lady who works for the actual county that supervises the peer supports. But I know that it demands specific budget allocations. And I don't feel like they're really like taking that seriously. I know that they're kind of like backed up on some money and some things. And that was like, I wanted to know how, like, as an advocate, I can like have a better voice with that. If you have any suggestions, or
Yeah,
like how to hold them accountable, like for them following those guidelines that are coming up.
absolutely. That's a really great question. I will say, one, sit through the rest of this webinar so that you're just educated generally as to what's going on, because when you can speak to them and ask them a question that's meaningful with their language and these rules, you're more likely to get an answer. If your question's very pointed, I guess I would say, or has a lot of context to it when you ask the question. The second thing I will say is I think that up until very recently, counties just didn't have enough rules to be able to answer specific questions because the law was literally still being written. So I don't know when exactly you met with the county, but they might not be able to answer the question because they're still trying to digest all of these new rules and how they can comply with them and what they mean. So I don't know if the counties I don't know if counties are necessarily trying to be evasive, or whether this stuff is just so complex even for them that they're still trying to figure it out. But if you sit through the rest of this webinar and we can give you other resources, I think you'll see like where to ask a meaningful question. Is that helpful?
Okay. Yeah, it is. Maybe even after I could ask you some more specific questions when it's not in the middle of, yeah. Thank you.
Absolutely. Yes, you can. We're very informal here, so this is fine. All right, I'm going to move forward if there's no other questions. So again, to go back to the pillars analogy, we have money coming in, that's one pillar. We have the rules for how to spend it, that's one pillar. And then we have the process to apply those rules. That's the community planning process. And so what the statute said, what the law said, what the people enacted was that with this MHSA tax revenue that's coming in, a 3-year expenditure plan will be developed with local stakeholders, including people with lived experience, and other specified people. And the counties will demonstrate a partnership with these stakeholders throughout the process of planning for and spending MHSA dollars that is meaningful and involves meaningful stakeholder participation regarding just about everything, right? Policy, program planning, implementation of these plans, monitoring services and programs for how they're really doing, improving their quality, evaluating what's being funded and whether it should remain the same, and to the question that I just received, budget allocations. And actually that didn't change in the Behavioral Health Services Act. So one thing that you can ask your county for directly is, show me your budget allocation, show me where the money is going for this or that, and then I'll stay online afterwards for some more specific questions around that. And so, as most people are familiar with, the MHSA community planning process involved developing this 3-year program and expenditure plan, demonstrating how the county would spend their MHSA funds. And also those plans had to be updated annually and could be updated intermittently if things change. The county MHSA funding allocations had to include funding for the annual planning costs. So it costs money to pay staff to hold meetings and meet with the public, to have a public forum, to have this planning process. So the BHSA actually gave counties the permission to use some of their MHSA dollars to educate the public, the relevant stakeholders, people with lived experience, to bring them into this planning process so that they could meaningfully participate. So the people that enacted the statute and the people that wrote it envisioned that community members would need some kind of education to be able to meaningfully participate, like the county's responding and giving the person information or even education. So those planning costs, to educate the community and engage the community, were available, and still are. So that was another important part of the community planning process and the MHSA funding for it. And then for people that have been through it, they're roughly familiar with how it goes. There is a whole period of engagement and planning for the use of these funds. And then that plan has to be presented to the local mental health board. And that local mental health board had to conduct a public hearing on this draft 3-year plan, and hold open a 30-day comment period. And then when the comment period was over, the local mental health board votes. It's an advisory vote to approve or disapprove of the plan. And then the county board of supervisors has the official vote that really counts. So that's a very rough sketch of the community planning process. And where we really saw detail about what that process was going to look like is in the right-hand bottom of my slide, 9 CCR section blah, blah, blah. Title 9 of the California Code of Regulations. These are the regulations to MHSA. These were written by DHCS in consultation with the public and formally put in the law. So under those regulations, that's where we got the detail about what the community planning process was supposed to look like. And these regulations said things like counties shall ensure that stakeholders have the opportunity to participate, including people from unserved and underserved populations, including folks that reflect the diversity and demographics of the county, including folks with lived experience and their family members, and including that the county shall provide the training for these stakeholders so that they can know what's going on and meaningfully participate. Counties also had to adopt the Mental Health Services Act 6 general standards in planning and implementing and evaluating for all the programs and services funded by the MHSA. And so folks that have been involved in this process in the past are familiar with this. These are the 6 general standards under the MHSA, again, as spelled out by regulation. There's supposed to be community collaboration, and there's a definition, and that means a process by which clients and families who are actually receiving services in the system, and secondarily, other community members, agencies, organizations, or businesses work together to share information and resources in order to fulfill a shared vision and goals. Cultural competence. All the MHSA planning was supposed to be guided by and adhere to, incorporating and working to achieve into all aspects of policy making, program design, and administration and service delivery, what cultural competence means, which is collaterally defined as well. But we're looking for programs and services that assess for strengths and weaknesses in the proficiency to achieve cultural competency and ways in which systems can be transformed to be more culturally competent. So trying to do this was one of the guiding requirements of MHSA planning. That the whole system be client driven, which means that clients have primary decision-making roles in identifying their own needs, preferences, and strengths, and shared decision-making in determining the services and supports that will be helpful for them. Client-driven programs and services use clients' input as the main factor for what we're doing or trying to do with these dollars and in this process. It was also supposed to be family driven, which means that families of children and youth with serious emotional disturbance who have a primary decision-making role in the care of their own children, including the identifications of needs, preferences, and strengths, and that those family members who are guardian parents, caretakers, have shared decision-making role in determining the services and supports that would be most effective for their children. So that's another one of the general standards that was supposed to guide and govern over all of this from the regulations. The MHSA was supposed to be a wellness, recovery, and resilience focused set of services and programs. And so everything that was being considered for funding or to stand up a program or service was supposed to adhere to the recovery vision and philosophy and principles for mental health consumers. And obviously these are extremely important as many systems don't even attempt to achieve these goals when it comes to mental health treatment. The general service standards for adults and older adult clients, which were in the statute to MHSA, were also one of the goals and guiding principles of the community planning process. So the general service standards required that there be family supporters and have consultation with those people, parenting support, peer support or self-help groups, that the provision of services be client directed, that they be employing psychosocial rehabilitation and recovery principles. And individual service plans needed to be designed to enable clients to self-manage their illness and exert as much control as possible over both their day-to-day and long-term decisions that were going to affect their lives. There was also a requirement that the community planning process aim at integrated service experiences, which means the client and, when appropriate, the client's families assess a full range of services provided by multiple agencies, programs, and funding sources in a comprehensive and coordinated manner. So the folks that were going to be served through the MHSA really needed to have an integrated service experience, and that we were trying to design and fund programs through the MHSA that would complement and not be sucked into different forms and modalities. So again, the MHSA community planning process lives a great deal in the regulations. And it means the process to be used by the county to develop the 3-year plans and annual updates in partnership with stakeholders, to identify the community issues related to mental illness resulting from the lack of community services and supports, including any issues identified during the implementation of the MHSA, analyze the mental health needs in the community, identify and reevaluate priorities and strategies to meet those mental health needs. So the local process was really supposed to be to continuously improve programs and services at the local level and in accordance with local and unique needs. But again, this was mostly written into the regulations to MHSA. The regulations to MHSA also required that the counties had to clearly designate a person responsible for the community planning process within the county and be adequately staffed to be successful and inclusive in the community planning process. Obviously, the CPP had to include consumers with serious mental illness and families with children with serious emotional disturbance. It needed to be comprehensive and representative, and provide training for county staff and stakeholders to understand what this whole thing was supposed to be about and how to engage in it. So people have probably seen this graphic from our organization before, but this is just a graphical representation of all those things we just talked about in the regulations. You had these general standards like a client-driven, community-driven, culturally competent system. Everything was supposed to adhere to that. And then those general standards would guide the community planning process in addition to the money spending rules, like spend half of your CSS dollars on full service partnerships. That community planning process was supposed to produce 3-year plans and update those plans annually. There's a local review process of the plan, goes to the mental health board. The mental health board leaves it open for public comment, holds a public hearing, makes a recommendation, and then the board of supervisors ultimately approves or disapproves of the plan at the local level, goes up to the state. But this is focused on the local level. And this is sort of a different graphical representation of the life cycle of these plans. So you have the community planning process at the top. They create a draft 3-year plan or annual update. There's that local review process, which is the mental health board review process, public hearing, notice and comment period. And then once that plan is finalized and approved at the local level, board of supervisors goes up to state people, and back around we go. So blah, blah, blah. That was a lot of review, a lot of talking about things people mostly have experienced and know about. But the things that I want people to take away as key takeaways is that, again, much of what we think of the MHSA community planning process is spelled out in and required only by the regulations to MHSA. The community planning process can be fundamentally altered by changing MHSA funding, right? Like if the state just decided y'all get only $1, that would fundamentally alter the community planning process in an indirect way. If the community planning process can be fundamentally altered if the spending rules, once you get the money, fundamentally change, and the community planning process can be fundamentally altered if you just go right after it in the law or the regulations and say, we're not doing it that way anymore. Here, it's changed. So those are all the different ways that the community planning process can fundamentally alter, right? Pillar 1 changes a lot, Pillar 2 changes a lot, or Pillar 3 itself changes. So that kind of wraps up this section of kind of a little bit of a review of the MHSA and the community planning process. And so the point of this section again was to review where we've been, especially how much of this law that exists now, the MHSA, was written by the people through a ballot initiative, how much was written by DHCS, and that whole thing together, the statute and regulations, when it changes, who changes it, how does it change? So the key takeaways from section 1 and looking forward to section 2 are that Proposition 1 in the Behavioral Health Services Act did fundamentally change all 3 pillars of the MHSA. The BHSA changes the funding amounts, which everybody already knows. It changes the fund spending rules in both the statute and through new regulations to BHSA that just got done being written. But then the BHSA also changes the community planning process, both directly and indirectly. It changes it directly because the regulations that we just talked about for the community planning process itself have been potentially or definitely overwritten and are wiped out, and there's something new there now. And the BHSA changes the MHSA community planning process indirectly because of how much else it changed in pillars 1 and 2, how much else it changed about the money coming down to the counties and how the counties were permitted to spend that. So I'm going to pause there. And Joss, can you tell me if you see any hands in the hands up?
Michael had a question in the chat a little bit earlier regarding stipends money. It was referencing something earlier in the section though, so I'll let him come off the mic and elaborate on it a little bit more.
When you were talking about for planning for education of staffing and things like that, is that where the stipend money comes out as well, or is that a separate pot that the stipend money for clients would come out of?
I think I understand what you're saying. So it's not a separate pot, right? So let's say if you, what county you're in?
San Mateo.
Yeah. Okay. So let's just say San Mateo County gets $100 million from the MHSA in 1 year. And the MHSA says 5% of that $100 million can be used by the county to train community stakeholders to engage in the community planning process. So it's right off the top of their money. So it doesn't come out of a particular bucket, but it's right off the top of everything they get from the state. And that continues to be the case. There continues to be a permission to use some of the money that's coming down up to 5%. From the state to the counties to engage in the community planning process, including going out and teaching people who are peers or clients, consumers, what the heck is going on and how they can participate. Does that answer your question?
Yes, it does. Thank you.
You're welcome. Any other questions?
That's all I'm seeing so far.
Okay. Yeah, I'm so sorry, Joss, but I don't know why when I'm presenting in this view, I can't open either the chat or the participants. Okay, so on to modern day. Part 2 of this training is really a little bit of an overview of the Behavioral Health Services Act, but again, with the eye of saying, how does this affect the community planning process? 3 pillars, they're all changing. So let's look at how pillars 1 and 2 indirectly affect the community planning process, and then pillar 3, which is the community planning process itself, how that has been changed. So again, pillar 1 is Behavioral Health Services Act funds and key takeaways there. Pillar 2 is the Behavioral Health Services Act spending rules and the source of those rules, statute or regulations, and some key takeaways there. And pillar 3 is the Behavioral Health Services Act community planning process and some key takeaways there. So as most people are familiar, one of the big changes from the MHSA to the BHSA is the counties got fewer dollars. So under the MHSA, the share of tax revenue that was going to the counties was 95%. And under the BHSA, it dropped 5% to 90%. So now of all the tax revenue that is collected, 90% is going down to the counties instead of 95%. And while that doesn't sound like a big deal, when your tax collections are about $2 billion a year, 10% of that's still a pretty big bite for the counties. So the counties have fewer dollars just off the top going down to them out of the tax revenue. And then obviously, actually, I'll go back to that slide because, I'll go over in slightly more detail. The other big change is obviously that the subparts, when that money comes down, when that 90% comes down, the big buckets, the subparts that you have to spend it on changed. We didn't used to have a category called housing interventions. Now we do. We still have full service partnerships at roughly the same level of funding. And then everything else that people are familiar with, prevention and early intervention, outreach and engagement, general services development, wellness and recovery centers, all of that got shoved into one piece of the pie, the kind of catch-all piece of the pie, behavioral health services and supports. So that was also a big change. And in terms of folks that are used to planning for service dollar spending, the BHSA didn't increase the tax, so it didn't increase the revenue. Instead, it shifted things around. So a great deal more money was shifted into housing interventions, which are what they sound like. They are the roof over your head and the lights and the water running in the sink. They're not for services. And so that big shift affects the community planning process because the service dollar spending is relatively lower, housing interventions spending relatively higher. And so the community's role in shaping where dollars go is diminished. And then within the other big change is that within those big categories, there's lots of other spending roles. So for housing interventions, the one that most people are familiar with is that half of the housing dollars have to be spent on those who are qualifying as chronically unhoused under federal rules within a focus on encampments. And there's other roles in the behavioral health services and supports, the green category that's now kind of the catch-all category. Half of those dollars have to be spent on early intervention. The fewer 5% that the counties now get went to the state for what's called prevention. So prevention and early intervention were broken up, and the counties now are only allowed to spend for early intervention and not prevention. But again, kind of focusing on the community planning process, the key takeaways are that the BHSA did reduce the amount of money counties receive from total tax collections by 5%, leaving less money for county programs and services to be planned for and spent through the community planning process. The BHSA shifted the fundamental categories in the MHSA, adding housing interventions as a new mandatory category, and that also affects how much money is available for the community to design something they want in terms of a program or service. And because of that loss of flexibility, the community planning process is being altered through Pillar 1. I'm going to stop there for any questions.
No new questions right now.
Okay, I will keep going. Oh,
Wait,
Kimberly has
one
her
hand from Kimberly.
Got one.
Go ahead.
So what I'm seeing is now only 35% goes to behavioral health services. And then half of that is on early intervention and prevention. Is that right?
Yes. So 35% is going to the category called behavioral health services and supports.
Right.
And then they put early intervention. They eliminated prevention from prevention and early intervention and said that half of the behavioral health services and supports dollars have to go to early intervention programs, and then half of that has to be for folks under the age of 25.
Right.
there are just, and so I know people have sort of said, when all this money shifted into housing, where did it shift out of? It primarily shifted out of what we used to call um, community services and supports, general system development, and I'll say a little bit more in a minute about that.
Okay, thank you. I just don't think it hit me in quite the same way yet. I just got it. Yeah,
No, I know there's so much to get that honestly, sometimes I'm like, oh, this light bulb for me that does work
yeah,
on this all the time just came on 2 years later.
it's devastating, you know?
Yeah. Okay. So now let's talk about pillar two, right? So pillar two is not the amount of money that's coming down to the counties, but those bigger rules about how to spend it, the more broad rules about how you have to spend it, can spend it. And so obviously one of the fundamental changes from MHSA to BHSA was the inclusion of substance use disorder treatment services as able to be funded by these dollars. BHSA funds may only be spent on programs and services now for adults with serious mental illness, children with serious emotional disturbance, and or adults and minors with moderate to severe substance use disorders. So that's another way that by changing pillar two, the funding spending rules, it changes the community planning process because now the community has both a new option, spend for substance use disorder treatment services, but also a new population with the same pool of funds. So money spread around a little more thin. I see that I believe Stuart has a hand raised.
I've been a member of Oxnard Behavioral Health North since around 2012 when I learned of something called RAP, Wellness Recovery Action Plan. And I contend that if all the clients were required to take RAP, which involve what you learn there is if you do your daily maintenance, things like getting up, showering, brushing your teeth, taking your meds, whatever, and that can change, you would be less likely to need intervention, thus saving a significant amount of money. And it also uh, teaches clients that if things are breaking down, there's things you do, like you get in touch with your case manager, uh, you go for a walk, get some kind of distraction, diversion, whatever. And it also has, if that doesn't work, when things are breaking down, there are further steps to follow. And lastly, in the event you get hospitalized, you've already pre-established something called a crisis plan. Who you want as your supporters, which hospitals you want to go, which ones you don't want to go, meds, so on and so forth. I I would recommend that you look into that and consider how that could help.
Yeah, I think most people in the community are pretty familiar with RAP. It's a helpful tool for people that embrace it. And actually, RAP groups were something that have been historically funded through the MHSA, especially as delivered by peers, especially in non-traditional settings like wellness and recovery centers. But let me refocus on the content for this, which is, so just to reiterate, so we don't totally lose the trajectory because I have a lot to tell you. The BHSA statute, right, changes the community planning process because now the community has a new thing that they're allowed to plan for and spend for, which is substance use disorder treatment services, but also a new problem, which is that it puts people with only a substance use disorder in competition for the same funds of people with only a serious mental illness. The BHSA statute also creates three main authorized programs and spending categories, which we already talked about. a little bit housing interventions, full service partnerships, and behavioral health services and supports. And it also said that these programs and services have to be prioritized to certain populations within the community of those with mental illness or substance use disorder. These services have to be prioritized the unhoused, chronically unhoused, those exiting incarceration, those at risk of institutionalization or exiting institutionalization. There's a big long pecking order. And I mention this only because if you're starting to feel like the level of complexity is going way up, it is. And that affects the community planning process. So the BHSA statute, the law written by the legislature, also directed the Department of Health Care Services to get as much money as they could from the federal government in Medicaid reimbursements and to use the BHSA dollars for that purpose. And so this is like one place where it said it a bunch of places in the law. The Department of Health Care Services shall seek approval of all applicable federal Medicaid approvals to maximize the availability of federal funds and eligibility of participating children, youth, adults, and older adults for medically necessary care. Let me unpack that for you. Health insurance is like poker. You ante up. So the way that federal health insurance, specifically Medicaid, which we call Medi-Cal in California, works, is that if the state of California will ante up with 50 cents for, let's say, glasses, prescription glasses, then the federal government will ante up back 50 cents for those prescription glasses. So it's a way to share costs between the federal government and the state of California. And it is a way for the state of California to, instead of, paying 100% of the cost of contact lenses with no health insurance coverage, it could choose to use the money that it was paying for contact lenses and ante up for glasses with the federal government. So I don't know if that totally makes sense to people, but basically the BHSA said, you, Department of Healthcare Services, go make as many ways to bill Medi-Cal as possible, create new ones, create new insurance covered services, and then we'll use these BHSA dollars for those insurance covered services, because if we do that, then we've got the federal government anteing up into the pot. We've got the federal government giving us some money for what we're doing instead of us doing it on our own with our own tax dollars with no assistance from the federal government. So the key takeaway here from how the BHSA changed the spending rules around these tax revenues is that substance use disorder without co-occurring mental illness was added. There were new mandatory spending categories, primarily housing interventions, that were added. And the BHSA requires BHSA dollars to be used to the extent possible to pay for health insurance covered services, and directs DHCS to go ask the federal government to expand those health insurance covered services. So this affects the community planning process through Pillar 2, because the state is now telling the counties, you have to use these dollars for health insurance covered services at the expense of non-health insurance covered services. You have to go try and get the federal government to give you more money. You have to spend on housing instead of services. And also there's a new permission to spend on substance use disorder, but also it creates funding competition with serious mental illness. And all of that affects the community planning process because there are fewer dollars for the community to create new programs with. And there are a lot of new rules to use these dollars for health insurance covered services instead of non-health insurance covered services. I'm going to pause there because I feel like that was kind of a mouthful and it's really important. So if anybody has any questions about that, I'll pause here to see if there are any. Any, Jocelyn?
Doesn't look like it.
Okay. So if that weren't complicated enough for y'all, the BHSA statute also said, again, it's the Department of Healthcare Services who can write regulations. So, right, we have one law, but it's being written in two different parts by two different groups of people. We had a law that was passed by the legislature, Senate Bill 326, that created the Behavioral Health Services Act statute. And then that statute said, and the Department of Healthcare Services can write the rest of this law on their own. So that's what's been going on. And the result of that is the Department of Healthcare Services Behavioral Health Services Act County Policy Manual. It's not a suggestion. These are laws that are in this manual. These are things that the counties have to do. And so, like I said, they were still writing what the Behavioral Health Services Act would mean up until April, about 6 weeks ago, when they released this county policy manual that is actually the regulations to the Behavioral Health Services Act, and that wipes out a bunch of regulations in the Mental Health Services Act. Again, the regulations to BHSA are contained in and are called the BHSA County Policy Manual. The complete Behavioral Health Services Act is the statute that was passed by the legislature and put on the ballot, but then also the regulations that were written by DHCS all taken together. So it was only as of April that the Behavioral Health Services Act is now complete as a law, completely written. And while it's a complicated legal question in some ways, I will come back to it, but a lot of what we talked about as being the rules for the community planning process were basically overwritten because they were regulations and they could be overwritten by the Department of Healthcare Services. And now the Department of Healthcare Services effectively has overwritten them. So it's a whole new ballgame. And I think that's very confusing to some people in the community who it is not clear yet to people which set of rules are the rules for the road. It's the new rules. It's the rules in the county policy manual. And now, just for the sake of being a little bit more illustrative, I'm really do not have the capacity, none of us do, to go through in detail all the ways that this new county policy manual additionally changes what the Mental Health Services Act was and defines what the Behavioral Health Services Act will be. I can't go into extreme detail. I'm just going to give you the flavor because, again, these are the detailed rules that apply in the community planning process. So if you even want to be involved in the community planning process, people are going to be talking about these things and you'll be like, okay, I kind of see what happened here. So for instance, let's look really quickly at the housing intervention money in the regulations to BHSA, the part of the Behavioral Health Services Act that the Department of Healthcare Services was allowed to write on its own, did write on its own, and has now published. So this is just roughly what's there. You can see who the eligible populations are, who's eligible to be housed through the Behavioral Health Services Act. What does housing even mean now? It's really been overwritten from the MHSA. So involuntary, court-ordered, and long-term institutional care looks like a green light there. Law enforcement purposes, temporary housing, and housing navigation. It's not all just regular housing. Some of it's clinical facility type stays. So, housing can be temporary, it can be through a court order, and it can be in what qualifies as a clinical treatment facility. Again, you're supposed to use as many of these housing dollars, even though they are housing dollars inside of health insurance, because Medi-Cal, Medicaid through CalAIM did things like make transitional rent a billable health insurance covered service. So now you can use these housing intervention dollars in the BHSA as the ante up to get 50 cents from the federal government for transitional rent, say, or something similar. But I will say that housing for persons with substance use disorder only is optional for the counties. So when the state says counties, you have to spend 30% of your Behavioral Health Services Act dollars on housing interventions, it is optional to house people with substance use disorder. It is mandatory to house people with mental illness. And then on the right side of the slide is really that both allowable settings for people are temporary or permanent homes, and real definition of what those dollars can be spent on. Like it's okay to spend to house people temporarily in motels or congregate settings, tiny homes, and in permanent settings, it's okay to house people in apartments or homes or nursing homes or licensed or unlicensed boarding care. So you can kind of get the flavor that this is so different from the MHSA that it was the Department of Healthcare Services that got to write this huge part of the law, and it is overwriting and superseding and wiping out what was in the MHSA. So again, this is not meant to say everything that's there, it's just be illustrative. So same thing with full service partnerships. There's now a lot of rules that were just published that say what you have to do in a full service partnership. They say that there has to be levels of care. There's intensive case management for the people with the lowest level of care needs, says who's eligible for that. And it says, what the ratio of team members to clients has to be, who has to be on those teams, how often they have to quote unquote contact a client per week, and what sort of services should be available depending on whether the client needs them in this full service partnership. So you can see this is very detailed and regimented. Assertive community treatment and forensic assertive community treatment are also just models of intervening with people. They're team-based models, and they involve, offering certain kinds of interventions to people. This is mandated for counties to have in their full service partnership programs. So again, and this is me making it as simple as possible. These are very detailed and complex rules, and you'll note people with substance use disorders only cannot receive assertive community treatment or forensic assertive community treatment in an FSP. On and on we go. Very complicated. But there are, new mandatory services in a full service partnership, and this was created and written by the Department of Healthcare Services, not by the legislature. So things that have to be in every county's FSP, big county, small county, doesn't matter. You have to have teams of people that will go out on the streets to help people who have substance use disorder get hooked up with medication assisted treatment, which is like Suboxone, methadone, opioid, synthetic opioid, harm reduction replacements for street drugs. So these street level outreach and engagement teams are mandatory. And there are also things those teams have to do, like targeted engagement. Somebody goes to an ER with an overdose of fentanyl. They're going to try to track and follow up with that person. Open access clinics, that peer support be offered, and that counties pay for MAT prescription drug costs. So again, just very detailed and written by the Department of Healthcare Services in the regulations. Other things that are optional in full service partnerships, what's called the individual placement and support model of supported employment. And so in the right hand of my slide, I just copied that right out of their policy manual to give you an idea of what that is. It's employment specialists helping people with mental illness or SUD with sort of pre-employment related services. And then if they get a job, helping them try to sustain being employed. Good service, optional in an FSP. So again, these are just illustrative only. What I want you to take away from it is that there's a lot of detail here, and there's a lot of things counties have to do. and that affects the community planning process because the counties have less flexibility. They have all these things they have to do. They have no options around. And so that leaves less for the community to do, right? And I'll go over that a little bit more as we progress. But I will, because I promised, touch briefly on the behavioral health services and supports subcomponent of the MHSA, which, as Kimberly rightly said, is now 35%, and half of that 35% is for early intervention programs, and the rest is for everything else. And I will just again point out, for the sake of illustrating how detailed these regulations are about what you can and cannot do with BHSA dollars. I'm not expecting people to absorb all of this. I just want you to have an appreciation for how detailed it is. So this is from the policy manual. They have defined what they think prevention is and what they think early intervention is. And so since prevention is now something they're only going to let the state do and not the counties, and the counties can only do early intervention, all of those existing PEI programs have to fit into this new mold, where you can only do two types of services for a client, what's called indicated prevention or case identification. And everything you're doing has to fit into that. And then there's a whole bunch more bells and whistles on top of this. So if that all weren't complicated enough, or kind of to tie it all up with a bow, if we go back to one of the things that was new in the BHSA and changed fundamentally from the MHSA, is that the state told the counties they have to use these dollars for insurance covered services. And the statute then also told the state, go make new insurance covered services so we can use those dollars for that purpose. So that is what happened just a couple months ago, that this was approved by the federal government. So you will be hearing about this, BH Connect, if you're involved in the community planning process. BH Connect is an acronym, but what it really means is that it is a program, a source of funding where the state of California went to the federal government through its Medicaid program that we call Medi-Cal in California and said, hey, we want to create a bunch of new insurance covered services. We want to cover things through insurance that we didn't used to cover through insurance. And we will use these Behavioral Health Services Act dollars to pay for the half cost of these new insurance covered services. So this is quite complicated. I won't go too much into it, other than to say some of the things that are now insurance covered services that didn't used to be, and that you have to use BHSA dollars for, and that the counties don't really have an option around, is assertive community treatment and forensic assertive community treatment, individual support and placement model of supported employment, clubhouse services, enhanced community health workers, and or peer support, including a forensic specialization as defined by DHCS. There's some other little things on this slide you'd be like, what is she talking about? I'll just say roughly, by hook or by crook, by one way or another, counties are becoming obligated to offer these new insurance covered services and to pay for them with BHSA dollars. This is just an informational slide about one of the ways that this new Medicaid initiative between the state of California and the federal government obligates the counties to do a whole bunch of things, whether it's really clear in the community planning process that they have to or they don't. They do. And again, it's kind of a trade-off. You know, the federal government gave the state of California some money for people to be in mental hospitals that it doesn't usually do. But if they were going to give the state of California money for people to be in mental hospitals, then the state of California was going to have to do some things that didn't suck, like have better outpatient services. And so that's what this is all kind of about. And I'm going to skip that slide just to go to the key takeaways. So I went a very long route to come to some pretty simple takeaways. The BHSA regulations are extremely detailed and specific. as to what counties can fund with BHSA dollars and for whom. And the BHSA regulations require the counties to opt in to optional new health insurance covered services with their BHSA dollars. But when you only have one pot of money and you keep making it dedicated to a billion different uses, what ends up happening is that when you use BHSA dollars for insurance covered services, that reduces or eliminates funding for non-insurance covered services like a peer warm line or a wellness and recovery center. And because these regulations to BHSA do all of that, they put so many 10 commandments on the counties that really greatly affects the community planning process, because there's everything that I just went through in a very, very short form is things the counties have to do, and they have to do with their BHSA dollars. And when the state is telling the counties that they have to spend their money a certain way, that means the community doesn't get a word in edgewise, right? The community can say, well, we really don't like, we don't want clubhouses so much. We want wellness and recovery centers. And the county is going to throw up their hands and say, we have to. And so that's why changing these two pillars so radically also changes the community planning process. What is the community to plan for if there's not dollars and there's not permission? What is there for the community to plan for if it's all been planned? That's the issue. I am going to stop there for any kind of questions.
There's a few things in the chat. Stuart gave some comments regarding RAP counseling and immigration. So Stuart, if you had a specific question in there, you're welcome to raise your hand. And then Cecilia had a question, curious about the employment piece, employment placing and training.
Cecilia, I'm not sure if that question is related to peer workforce issues. So there's two different things going on. I can go back to the slide so that we're using the same language. This individual placement and support model of supported employment, this is a service for clients that are receiving services through the BHSA to help that person achieve any kind of job that they want to achieve, not just be a peer. It helps them obtain a job, and then also is supposed to help them sustain in that job, keep that job. And the people that are going to be performing this service for a client in a full service partnership or receiving services through the BHSA is an employment specialist. They didn't really say that I've seen yet what the qualifications of an employment specialist are to be providing this service to folks with serious mental illness or SUD in the public behavioral health system. Now, because the language is so confusing, there are also a couple of programs under the BH Connect Medicaid waiver that are not that at all, have nothing to do with that. They are actually for peer workforce. What is the name of the program? The Peer Workforce Personnel Placement and Training Program, right? Those are the dollars that allow people to be trained as peer support workers, hopefully for free to them, and pay the trainers to do it. There is workforce money in BH Connect for peers to become peer support workers, but it's unrelated to what we were talking about here. I hope that answers the question.
Gotcha. Thank you. Yeah, I'm an employment resource specialist for a county, and I also work for a warm line, and I work in wellness and recovery. So it was just interesting what you were saying. I guess we'll just have to wait and see what that looks like.
Yeah.
Thank you.
Yep. Okay. Since I go so long in these trainings.
So there's one more question in the chat.
Oh, what's that?
And this is from Rukaya, and I'm probably saying your name wrong, so you can come off mute and correct me on that if you'd like. But asked, wait, so all counties are required to opt into the IMD waiver and the assertive community treatment, et cetera, or is it still optional for counties? And if they do opt in, then will they also be required to implement the assertive community treatment?
Those are really great questions. And it's massively complicated. And so, I mean, I'll touch on it very briefly, but I don't expect people to fully, because of the redundant and complicated way that the state did this, it's really hard to follow. So like the BH Connect waivers actually have separate pieces, and they're here. Some of them are here. Some of them are here on the screen, right? There is the BH Connect Access, Reform, and Incentive Program. There is the BH Connect Institutes for Mental Disease IMD waiver program. There is the BH Connect Workforce Initiative. These things are all separate, and counties opt into them, generally speaking, separately from one another. Where it gets really, really complicated is where these things overlap. So like, for instance, BH Connect says if a county is going to opt into the Access, Reform, and Incentive Program, which is essentially just extra money to make your system better. If you're going to opt into this extra money to make your system better, then you also have to offer assertive community treatment, forensic assertive community treatment, supported employment, clubhouses, ECH, and peer support. And that requirement is completely separate from the BHSA policy manual, where it says counties have to offer ACT and FACT in their FSPs. If that is utterly confusing to you, you're not alone. But basically, there's separate and redundant places where counties are either incentivizing and choosing to offer things with BHSA dollars, or the state found a way to make them in any case. I would say, to make it as simple as possible, there's zero question that counties are going to have to offer assertive community treatment and forensic assertive community treatment in their FSPs. And then what those things mean as spelled out can often include clients having access to the individual support and placement model of supported employment, or clubhouses, or ECHWs. And why it says contradiction on this is because also they have contradicted themselves right and left. But I will say, to my reading, I won't make an accusation in case I didn't read something right, but I will just say, so that's one example. It's like, okay, if counties opt into the Access, Reform, and Incentive Program, then they have to opt into these other things, but they also have to opt into some of them, not opt in, but actually they're required to provide them with BHSA dollars, regardless of whether they're part of this BH Connect or not. And then like the IMD waiver, this is an option, right? The counties can choose to get this extra hospital money or not. And if they choose to get it, then they have to do all these things. Utterly complicated. We'll say by hook or by crook, a lot of this money is going towards Medi-Cal, and it's mandated to or incentivized to in a lot of different ways. I hope that that was responsive and that was something people are able to follow, but it is very complicated. Any other questions?
I'm not seeing anything else at this time.
Okay, final stretch. This is the last part. So having, again, said all those complicated things, only for the sake of observing that they're different and they're complicated, we're now going to look at Pillar 3, which is the community planning process itself. And when they changed the actual law, the law written by legislators, the statute, what did it say that directly relates to the community planning process? It said, okay, well, you guys used to have MHSA plans for MHSA dollars. We have a new type of plan. We have a 3-year integrated plan for behavioral health services and outcomes. So the community planning process is supposed to be creating part of the integrated plan for behavioral health services and outcomes. So what the heck is that? Why is it different from an MHSA plan? It's different because an integrated plan is supposed to bring together and create one plan for all of the funding the county gets from any source for behavioral health services. So that can mean like your county has a local sales tax, and that local sales tax has been dedicated for SUD services. That money has to be planned for and spent in the integrated plan. Money from the state, the Behavioral Health Services Act dollars are from the state. That money coming down to the counties has to be planned for in the integrated plan. money from the federal government. The federal government sometimes gives what's called block grants to the states to help pay for mental health or SUD services. So if that money came in a block grant from the federal government and it trickled all the way down to the county, county has to plan for it and use it in this integrated plan for behavioral health services and outcomes, meaning there's no such thing anymore as an MHSA plan. The new quote unquote BHSA plans aren't BHSA plans alone. They're integrated plans of all the funding sources all at once. I hope that that is clear to people, but it's also if people are starting to feel like, OMG, how is anyone supposed to follow this? They'll talk to your county, they'll say the same thing. So what else did the law say about the community planning process? It said, if I would go all the way back to the general standards for MHSA, community driven, client driven. We're trying to improve these services so that people have better outcomes, better self-determination. All of that, those general standards are really gone now. And instead, what we have with the integrated plans for behavioral health services and outcomes is those plans they are aiming at something too, but they're aiming at these statewide outcome measures and improvement goals that have been set by DHCS really without the peer community at all. So these statewide outcome goals are laid out and they're also reported on in another report that's related to the integrated 3-year plan. It's called the County Behavioral Health Outcomes Accountability and Transparency Report. They call it the BODR. So the integrated 3-year plans, they really aren't trying to do the general standards of MHSA anymore. They're really trying to hit those outcome measures in this BODR. And counties are required still in the new law, even though all these changes, to conduct a community planning process prior to the beginning of this first integrated 3-year plan. Our first integrated 3-year plans will be due really May 31st, I guess, of 2026, which is coming sooner than it should. But one of the things that the statute changed from the MHSA is, okay, so we have this plan. It's a plan for spending over 3 years. But we might have to change it every year or intermittently. Well, under the MHSA, you had your 3-year plan, and then anytime there was an annual change, an annual update, or an off-calendar intermittent update, there was a community planning process. Community had to be involved. But they took that out in the Behavioral Health Services Act, so the only right that the community has to be involved in the planning of these programs and services is now at the beginning of the 3 years and not in the middle of the 3 years. I hope that's clear to people too. And then I just put all these words on this slide for the sake of, once again, illustrating that things have become very complex. So we're used to a fairly short list of folks that had to be engaged as stakeholders in the community planning process under the MHSA. I pasted this directly out of the law. This is the list of people that absolutely have to be at least consulted. The county has to reach out to develop these integrated 3-year plans. There's a whole lot of people, and people with mental illness or substance use disorder themselves are like one of an extremely large group of people. And so you can just look at that group of people and go, are there more of them or more of us? Are there more healthcare organization and hospital representatives, emergency EMT services, unions, public safety partners, aka cops? Like, are there more of them in the room, or more people who are clients and consumers in the public behavioral health system, more people with lived experience? Obviously, you can read this and know. Also just pasted this directly out of the law to compare to the MHSA. This is where they kept some of the language of the MHSA. It still says that a county shall demonstrate a partnership with constituents and stakeholders throughout the process. that includes meaningful stakeholder involvement on mental health and substance use disorder policy, program planning, implementation, monitoring, workforce quality improvement, health equity evaluation, and budget allocations. That's identical from the MHSA. The next part is not quite identical from the MHSA, but in the exact same spirit. And then the third part, which someone asked me about earlier in the training, remains the same from MHSA. So a county may provide supports, including but not limited to training and technical assistance to ensure that stakeholders, including peers and families, receive sufficient information and data to meaningfully participate in the development of integrated plans and annual updates. And the other thing that the CAP that's basically the same from the MHSA is there's a draft plan. It goes to the mental health board. The mental health board holds a hearing about it. That draft plan is held open for public comment for 30 days. And then that mental health board, now called behavioral health board, in an advisory capacity to the board of supervisors, either says this is a good idea or not. And so again, this is just more of the technical procedure about this. That is fairly comparable to the MHSA, except that, as it says here, in preparing annual and intermittent updates, a county is not required to comply with the stakeholder process. That's referencing the CPP. There is still money. I'm not sure if I put it on the slides. There is still money there's still an authorization for counties to use some of their BHSA dollars to engage the community and pay for the community plan process, including educating the community. So pillar 3, the community planning process, the regulations, that everything that I just talked to you about was what was put directly in the law by lawmakers. Regulations are written by DHCS. They just got done writing them, and they didn't add a lot about the community planning process. But I did note that they don't keep or integrate the community planning process as laid out as previously in the California Code of Regulations under MHSA. They say very little about what a county must do in the community planning process. They did not keep or integrate the MHSA general standards for the community planning process. And I think those are basically overwritten by these statewide outcome measures. It does not require a county to do such things as designate one responsible person at the county for the CPP like they did under MHSA. So it's kind of the Wild West. So going back to this graphic, that outer ring was the general standards to MHSA, that the systems be client-driven, family-driven, wellness, recovery, and resilience focused. That outer ring, I think, to my legal reading, is gone. The community planning process still exists, but there are so many new things counties have to do that are complicated as heck that I don't know how much money or how much flexibility or permission is left for the community to like create a new program or service. And I'll give you an example I've used from Sacramento County. Through the community planning process under the MHSA, and because of requests from family members, Sacramento County created and funded a program that was respite care for adoptive parents of children with serious mental illness. So they literally funded a summer camp where people that had chosen to foster or adopt minors with serious mental illness could have their own self-care by a special summer camp for their children to go to. That is something that was created completely out of the creativity and need and demand of the community. It's not something that health insurance covers, probably ever would cover. And so, you know, that kind of thing is going away, I think, unfortunately, because there are so many new rules, so many things counties have to do with these dollars, so many ways they have to do it. And they have to do as much as possible inside of health insurance and pay for health insurance covered services with these dollars. So all of that means, to my reading, that the community planning process still exists, but mostly on paper. 3-year plans are now no longer MHSA plans, they're integrated plans, and annual updates don't have to involve the community. The local review process, which is where the plan goes to the Behavioral Health Board, used to be called Mental Health Board, and that board holds a public hearing, takes public comment, leaves it open for 30 days, makes a recommendation to the Board of Supervisors vote. That procedural part of the community planning process remains the same. So the key takeaways, I think, looking forward is that the community planning process has been fundamentally altered because all 3 pillars have been altered. The BHSA changed the amount of money that counties receive. They receive less. The BHSA changed the categories of spending, like housing interventions, and added SUD. And BHSA requires counties to use BHSA dollars for insurance covered services wherever possible. And the statute also required DHCS to go create more of those, and they did. And those things are clubhouses, they are enhanced state community health worker, they are the supported employment. So DHCS both went and in partnership with the federal government created new insurance covered services, and then the BHSA regulations require counties to offer some of those and generally require counties to use as many dollars as possible for health insurance covered services. But again, that leaves less money for the community to invent their own system, invent something that meets their needs that might not be covered by health insurance. So the BHSA, both, directly and indirectly, really affects the community planning process. It did it by changing the law itself, called the statute. It did it by overriding the regulations in the DHCS county policy manual. But the takeaway is that you cannot really expect, what we're going to see on a go forward basis as being really like people have been familiar with in the past. That's it. This is a very long training. I warned y'all. But I am available to take any questions about the actual training. And if people don't have any questions related to the actual training, we can stop recording and I will stay online to answer the kind of collaterally related stuff people might want to talk about.
There's 2 questions in the chat from Rukaya related to the training. First one, given that the BHSA is so prescriptive while also claiming to involve community and planning, will there actually be opportunities for communities to try to advocate for language access, community defined evidence practices, etc. in the CPP? And then her second question was, how does CBH interact with all of this, if at all?
The Commission for Behavioral Health?
Yep.
Is this the question? Okay. So as to the first one, I think that I don't want to say there's no community planning process. There is. I don't want to say it's only on paper. It's just the range of things the range and the size of things that the community can directly influence has definitely diminished. Zero question about that. But that doesn't mean that if your real concern is that there be language access in full service partnerships, and I would be with you there. There's really poor language access for virtually every part of the public behavioral health system, and you really don't want to be the person in the situation of being in an ER in a mental health crisis where no one speaks your language, being in an acute psychiatric hospital where no one speaks your language, trying to navigate your benefits that are becoming more complicated when no one speaks your language. So I think something like language access is something you could effectively advocate for within the community planning process, even though so much has narrowed in terms of how much the community gets to invent. I think language access is something you could absolutely meaningfully change potentially through the community planning process. And then Joss, can you remind me, was the second part about CBH?
Sorry, I was muted. How does CBH interact with all of this, if at all?
So, I'm sorry.
If you'd like to come off mute and explain the question a little bit more, you can.
Yeah, thank you so much for this presentation. I just wanted to ask, like, I know in the past under MHSA, the MHSOAC would kind of like approve some of the county related programs and even things like innovation for community defined evidence practices and things like that. So I'm just wondering, like, is there still that sort of direct relationship between counties and the CBH now under BHSA? Is it different? If it's different, like how it is different?
Yeah, it is different. It's a little bit complicated to get into, but it is different. But you're not really going to see it is, so it's kind of your observation. These plans are really prescriptive, and most of the authority to approve or disapprove things is actually in the hands of DHCS now. Counties are permitted to still, I kind of have ignored the new rules around innovative programs because it was eliminated as its own funding category in the BHSA, right? It was its own funding category in the MHSA. It was eliminated as its own funding category in the BHSA, but then they just kind of said, and you can do something innovative in any of these programs, right? You can do something innovative in housing interventions. You can do something that's innovative in full service partnerships. But, and the approval process is one thing, but the second thing is there really any money left, right? How much does it cost to stand up all of these new programs and services? Is there even money left to innovate with? And then again, similarly with the OAC, I'm actually not entirely sure. I mean, they do. Oh, hi. Can everybody make sure they're muted if they're not talking? So, some of these things do exist, but the role of the Behavioral Health Commission is not the same, and they've expanded it and done other things. So yeah, you're looking at really, really significant changes there. I don't know. I mean, I don't know how else to express it other than like this is really very state driven now. And the state has its own ideas about what goals and outcomes should be. And there's a ton of new mandates to get everyone to face in that direction, for better or for worse. Any other questions?
Cecilia asked, when will counties start this? If it's going to start in July?
That's a really great question, Cecilia. So counties are already underway with this. Whether or not they've started to engage stakeholders as they were required to, I don't know. But for instance, some counties have already chosen to opt in to some of the new Medicaid expansions that obligated them to opt into other things with the BHSA dollars. That's already happened. There was a period open for counties to opt into this incentive program. But of course, if they opted into the incentive program, then they had to opt into all these other things and use BHSA dollars. That has already happened. So, the community planning process really should have started in terms of the counties now having enough rules to do the process because they needed that policy manual to be done, and it was completed towards the end of April. And then they need to have this whole process done by basically the end of March of next year. So this should, there's nothing in the law that says that the counties have to take 6 months to do it. You can't do it in fewer than 6 months. It doesn't say anything like that. So because of the complexity and difficulty in even understanding everything they have to comply with now, and then also engaging the community, and then also telling the community what they can and cannot have influence over, it's very complicated. So I think that the counties are mostly starting or trying to start now, and they may be at different stages in that process. I know some, like Sacramento County, is abandoning its old Mental Health Services Act steering committee as the way that it conducted its community planning process, and it's not really clear what the structure is going to be. So anybody's guess, but counties should get on it as soon as possible, especially if they have to change a lot, because client services are directly affected. They need to tell those clients what to anticipate. They need to stand up new programs and services, particularly like street outreach for substance use disorder. That's brand new for many places, and many counties would have to stand that up from scratch. So it's a lot. and they should be starting now that they can.
Thank you.
There's a question from Stuart, and it's specific to his county, but you might be able to answer generally. He was that information out for their counties.
Yeah, and Stuart, that's one of the things that's kind of difficult about the community planning process is even in the MHSA, it didn't really say that you have to do it is to have like town halls, is to have a place to go to where anybody from the public can show up, and everything that we're doing and thinking and making decisions on is done in a public way, in a public forum. And if we're going to vote on things, it's done publicly. You know, that may or may not continue to happen. So the community planning process doesn't require Ventura County to have a public hearing. It does require Ventura County, you know, in order to create these plans or do community engagement. What it will require of Ventura County is that, you know, 30 days before it's like June 1, 2026 due date, it has taken its draft integrated 3-year plan to its behavioral health board. Then the behavioral health board held one public hearing about that plan, about that draft plan. And then, you know, allowed public comment, written public comment for 30 days, then took a vote. So that's the only public hearing that's genuinely required by the community planning process. And whether your community planning process in your county is going to be conducted publicly in a public forum that is accessible to folks with meeting minutes and a record of what's going on, you're going to need to ask your county for that because it's not there in terms of being technically required. I'm going to stop sharing my screen. So I'm talking to people and not so much doing.
There's another question from Carrie. Has the state released any information for rural counties to opt out of the spending regulations?
So I guess I would reframe. Can you guys see me? I hate this new interface. Can you see me okay, Joss?
Mm-hmm.
You see me? Okay, I just can't see anybody else. All right. So yeah, so someone is indicating that essentially there's flexibilities for small counties, and there are, right? There are exemptions from doing certain things because it doesn't make sense in a small county or, you know, for their population, etc. So yes, small counties should know now what the rules are for smaller counties, what the exceptions and flexibilities are for small counties. And small means under 200,000 population, but I think that's still half the counties in the state. So there will be significant big county, small county differences if small counties choose to exercise some of those flexibilities and exemptions. All of that is either already in the statute of MH or of BHSA, so it's in the law written by the legislature, or it's in the county policy manual that was published by DHCS. So yes, that information is out there and certain as to what it is for the small counties. I don't think that am I missing any other questions?
I'm not seeing questions, just a few thank yous in the chat.
Thank you all for coming and having an interest in being engaged in your community. There's a lot going on in the world and it's affecting all of us, and this is but one tiny piece of it. So why don't we go ahead and stop recording, Joss?